All right. Thought we would jump back into some Kodachromes today. Sorry, it's been a little while since we've done some. Just gotten a little busy. So this is just a hodgepodge of some telederm and then inpatient consults that we had recently. This was an interesting case. Actually, we saw in person in my rheumatology dermatology clinic. This patient presented with these firm, painful nodules, mostly on the volar aspects of their palms. And what you see here is pretty much what I'm describing here, a single, well-circumscribed, smooth nodule. No real surface change, which tells you it's a dermal process. Mostly skin colored, maybe a vague brown hue to it, which could imply that there's some type of infiltrate, histiocytic or not. And so we're in a dermal inflammatory process, nodular, periarticular, and there's actually a differential diagnosis for that. There's not that many things that can give you these types of periarticular, dermal inflammatory, often histiocytic processes. One of the possibilities is a rheumatoid nodule that's usually seen more commonly in the dorsal aspects of the hands, but it can be seen on the volar aspects of the hands. Other possibilities, perniosis can look like this. It's usually a little bit more inflammatory violaceous rather than kind of brown. It's usually more at the distal tips rather than over the joints. Palisaded neutrophilic granulomatous dermatitis, also known as PNGD, can also look like this as well. It's usually going to be more micropapillar, a little smaller dorsal hands and on the elbows, more associated with rheumatoid arthritis, systemic lupus, or ANCA-associated vasculitides. Some parts of gout can look like this, like tophi can look like this, but a little bit less likely. In this case, biopsy revealed that this was actually a rheumatoid nodule. It was kind of cool because this patient had this presumed history of rheumatoid arthritis because of some joint inflammation and a positive rheumatoid factor, but CCP had been negative, and so they've been kind of waffling with the diagnosis of whether this was true rheumatoid arthritis, and so this biopsy and cutaneous manifestations were actually helpful here. This was a cute case. This was a telederm consult that I've already shared with the residents of a patient who had recently been hiking and then had this yellow-brown lesion present for 3 weeks actually, and kind of came to the patient's attention. I think this is in the axilla or the groin because there's an inflammatory response. And what you see here, really would call it like a papule, but basically this is an embedded tick. And what it is, it's head down, diving into the skin. This is his butt up that it's sticking up to the sky. And there's an inflammatory reaction because it's a foreign body. It's sucking the blood and injecting saliva and other foreign antigen that's leading to an inflammatory response. So we asked that they extract the tick, which they did. In terms of like how much you need to go into tick identification, if you're in an area where Lyme is endemic, it's something that could be worthwhile to see if it is truly one of the ticks that you're worried about. But for most parts of the country, it's usually kind of these spurious ticks that don't carry any diseases. Plus, in this case, this had been embedded for 3 weeks, well beyond a prophylactic window for doxycycline. So in this case, extraction is enough to kind of treat the patient. The inflammatory response will calm down. This was a telederm. I think it was like a 10 or 11-year-old boy presenting with these itchy patches to plaques on the plantar surface of the foot. And this is nice because I think this is a really nice classic example of this. What are you seeing? You're seeing a cracked, kind of shiny skin appearance to the plantar surface of the foot. Here it's very cracked. It's very inflammatory. It looks almost taut. It affects the instep of the foot going to the midstep of the foot and then onto the plantar aspect of the toe. And so this is actually a form of eczema. It's called juvenile plantar dermatosis. It's most common in young boys. It's thought to be due to maceration of the skin due to excess sweating. So, like a kid who's really active, has sweaty socks, leads to maceration, inflammation here, causes a local inflammatory reaction like a dermatitis here in a kid, and it's a form of eczema. So it's eczema caused by sweating, so you control the sweating as much as possible with absorptive socks, anti-sweating measures if needed, and then you control the eczema with topical anti-inflammatories. This is a nail case I thought was kind of neat, referred over to me for a colleague for biopsy. Just kind of a reminder that as dermatologists, we manage not just cutaneous diseases, but also nail, skin, and mucosal diseases. So here's a nail disease. What you're seeing here is lateral plate dystrophy. So here's normal appearing plate. Here's dystrophic plate. Looks very yellow, hyperkeratotic. You're also seeing hemorrhage here within the nail plate and within the proximal nail fold. This is not completely pathognomonic for an entity, but it's very suggestive of a specific entity. So when you see nail plate dystrophy, you know that there's a matrical problem. So the nail plate is generated from the nail matrix. So if the nail plate is dystrophic, there's something